Hi everyone, this is Dr. Shiwani Chaturvedy, and in this video I will be discussing about cataract. We'll start with the basics of cataracts. So let's begin. The cataract term comes from a Latin word cataracta, which means waterfall, because this term is used because the cloudy lens resembles the water flowing over the surface like a waterfall. A cataract is the opacity of a normal clear lens which develops gradually as a result of aging, metabolic disorders, trauma, or hereditary. The optics behind it is normal clear lens allows the transmission of the light. It focuses on the retina and the image is formed. Now what happens in cataract? The lens is cloudy, so it interferes with the transmission of the light and also it scatters the light, which leads to progressive visual impairment depending upon the stage of cataract. So this slide outlines the etiology of cataract. There is overproduction of oxidants leading to oxidative stress. Then there is sun exposure, ocular trauma, smoking, systemic diseases like hypertension, diabetes, mellitus. Long-term steroid use is a very known risk factor of cataract development. Then there is kidney disorders, which contributes by metabolic imbalance and accumulation of toxic substances. Then also there are genetic predisposition, which leads to the development of cataract. There are several risk factors for development of cataract. Let's break them into categories. So the most common one and the most important is aging. As we get older, we are more likely to develop cataract. The next main category is endocrine diseases. The most common one is diabetes, then galactosemia, homocystinuria, hypocalcemia, Wilson's disease, also malnutrition. Now, systemic diseases in general are atopic dermatitis, myotonic dystrophy, neurofibromatosis type 2, or HIV and AIDS. The ocular diseases which are linked to cataract are retinitis pigmentosa, chronic anterior uveitis, Stickler syndrome, and high myopia. Now, there are some medications which predisposes us to cataract development like glucocorticoids and acetylcholine esterase inhibitors. Also, the person who consumes alcohol or who smokes are more likely to develop cataract. If anyone has had any blunt or penetrating trauma or UV radiation, ionizing radiations or prior eye surgeries predisposes us to develop cataract development. Also, there are congenital infections, more specifically torch infections, which are linked to development of cataract. So, how the opacification of the lens occurs? There are three major biochemical changes. First is hydration. Excess water enters the lens fiber, causing them to swell due to osmotic changes within the lens or due to changes in the semi-permeability of the capsule. The second is denaturation of lens proteins. If the proteins are denatured with increase in the insoluble proteins, this will aggregate and scatter the light instead of allowing it to pass through it. The third one is slow sclerosis, which is a degenerative process which occurs and there is gradual hardening and degeneration of lens fiber over the time. All three processes leads to abnormalities of lens proteins and disorganization of lens fiber. As a result, lens loses its transparency and there is development of cataract. So cataract is classified based on morphology, age of onset, maturity, and etiology. Starting off with the morphological classification of the cataract, which is based on the anatomical location of lens opacity. First is capsular cataract, which involves the lens capsule itself. It is divided into anterior capsular cataract and posterior capsular cataract depending on which part of the capsule is affected. The second is subcapsular cataract, which occurs just beneath the capsule. This is further classified into anterior subcapsular cataract and posterior subcapsular cataract. The posterior subcapsular cataract is clinically important because it affects the vision early because of its location near the nodal point of the eye. Then there is nuclear cataract, which involves the central nucleus and is commonly associated with aging. The fourth one is cortical cataract, which affects the lens cortex and appear as spoke-like opacities in the periphery. Finally, polar cataract, which involves the central anterior or posterior pole of the lens, and it is often congenital. Pictures of different types of cataract we have discussed: the posterior subcapsular cataract and the polar cataract, the slit lamp view and the retroillumination view, the anterior subcapsular cataract, and the nuclear cataract and the cortical cataract on retroillumination view. Next is classification of cataract based on the age of onset. The first one is congenital cataract. This type is present at birth. The second is infantile cataract. This develops within the first year of life. Then juvenile cataract. This occurs from infancy to adolescence. Then there is presenile cataract, which develops up to 40 years of age, earlier than the usual onset of age-related cataracts. And finally, senile cataract. This is the most common type and occurs after 40 years of age. So this classification helps us understand according to when the cataract first appears in person's life. Etiological classification of cataract, which means classification based on the cause. First, developmental cataract, which develops due to abnormal lens development. Second is acquired cataract, which includes several types. The most common acquired type is senile cataract, occurring due to age-related changes. Next is traumatic cataract, which occurs following blunt injury, penetrating injury, radiation exposure, or electric shock. The image shows a typical traumatic cataract. Then metabolic cataract, seen in systemic conditions like diabetes, Wilson's disease, and myotonic dystrophy. For example, diabetes can produce like a snowflake cataract, and in myotonic dystrophy there is a Christmas tree cataract. Now what happens is, in a sharply limited zone of cortex underneath the capsule, there will be opacity both anteriorly and posteriorly, fine dust-like opacities, and the polychromatic dot and flakes in the superficial cortex resembles like a Christmas tree. This may be progressive or stationary as shown in the images. The next is drug-induced cataract, commonly caused by corticosteroids and miotics. Finally, complicated cataract, which develops secondary to chronic eye diseases like uveitis. This type shows characteristic features like polychromatic luster and breadcrumb-like opacities as seen in the. Now, some key points related to diabetic cataract. First, regarding the risk factor, diabetic cataract is commonly associated with poor glycemic control. The longer duration of diabetes and high HbA1c levels significantly increases the risk. Coming to the types seen, in young patients with poorly controlled type 1 diabetes, we commonly see snowflake cataract, which is shown in the image. In older patients, diabetes usually cause a senile type cataract with the earlier onset compared to the non-diabetics. Now, moving on to the pathogenesis. High glucose level in the lens are converted to sorbitol by the enzyme aldose reductase. Sorbitol accumulates within the lens, causing osmotic stress, leading to lens fiber swelling and opacification. In addition, there is increased oxidative stress due to generation of reactive oxygen species, which damages the lens proteins. Finally, non-enzymatic glycation of lens proteins further contributes to loss of transparency of lens. So, in summary, diabetic cataract occurs due to combination of osmotic stress, oxidative stress, and protein glycation, especially in patients with poorly controlled and long-standing diabetes. Now, with respect to the maturity of cataract, there is a stage of lamellar separation, stage of incipient cataract, then immature senile cataract, mature senile cataract, and last is hypermature senile cataract. Let's discuss this one by one. First one is lamellar separation, which is the earliest microscopic stage where there is imbibition of fluid between the lens fibers, which leads to separation of cortical fibers, but lens appears clinically clear. Generally, there is no visual symptoms at this stage. The next one is incipient cataract, which is earliest clinically detectable opacities with clear areas in between. The patient often complains of glare, colored halos, and blurred vision. On examination, there are water clefts and vacuoles in the cortex, and vision may fluctuate. Coming to immature cataract, the opacities become more prominent, but the entire lens is not opaque. The lens appears grayish white, but clear area is still present, so iris shadow is visible. It commonly presents as cuneiform cataract and cupuliform cataract. Now, what is cuneiform cataract? Wedge-shaped opacities with clear areas in between. It extends from equator towards the center. The opacities are present in both anterior and posterior cortex. Visual disturbance is seen in later stages. In cupuliform cataract, there is saucer-shaped opacity just below the capsule and it gradually extends outwards. And there is clear demarcation between cataract and the surrounding clear cortex. It causes early loss of visual acuity. Now, there is intumescent cataract, which is with progressive hydration of the cortical layers. There is swelling of the lens, thus making the anterior chamber shallow. Now, this is a picture showing intumescent cataract. And now, coming to mature cataract, at this stage, the process of cataract formation is complete and the entire lens becomes opaque. The lens appears pearly white in color, and because of complete opacification, no fundal glow is visible. Also, the iris shadow is absent, which is a key clinical feature of mature cataract, and the vision often drops to hand movement or even perception of light. In mature nuclear senile cataract, the degenerative changes intensify with dehydration. This leads to compaction of nucleus, resulting in formation of hard cataract. Now, this makes the surgical extraction difficult. Now, with time, the nucleus becomes tinted because of the pigment deposition derived from the amino acid tryptophan. The first image, it is cataracta brunescens, where the color of the nucleus becomes dark brown. The second one is cataracta nigra, where the nucleus becomes dark black. And the third one is cataracta rubra, where the nucleus has a reddish hue. Now, this table compares the clinical feature of immature cataract and mature cataract. Starting with symptoms, in immature cataract, there is partial loss of vision because only a part of lens is opaque. In contrast, mature cataract causes total loss of vision. Coming to the color of lens, the lens appears gray or grayish white in immature cataract, and in mature cataract, the lens appears white or pearly white. In immature cataract, the iris shadow is present, and in immature cataract, the iris shadow is absent. Regarding the Purkinje images, in immature cataract, the third image is seen and the fourth image may be distorted. In mature cataract, only the third image is seen and the fourth is absent. Finally, fundal glow, which is present in immature cataract, and fundal glow is absent in immature cataract due to complete lens opacification. Now, what is iris shadow test? It is a simple, quick bedside test and an important clinical sign to assess the stage of cataract. How to do this? A torchlight is directed from the temporal side and observer looks from front. If the part of lens is still transparent, a shadow of iris is casted on the lens. White occurs because lens is partially transparent and it allows the light to pass through it. And the opaque portion blocks the light, creating a shadow of iris. In immature cataract, because some of the lens fibers are still clear, the iris shadow is present. And in mature cataract, the entire lens is opaque, so light cannot pass through and the iris shadow is absent. Finally, coming to hypermature cataract, a hypermature cataract is a mature cataract that has progressed further, becoming swollen and associated with a wrinkled lens capsule. At this stage, the cataract requires surgical removal because it can lead to complications. There are two main types of hypermature cataract. First, one is Morganian, which is a type of hypermature cataract. There is complete liquefaction of cortex, which causes the dense nucleus to sink inferiorly. And the liquefied cortex appears milky white, while the nucleus is seen as a brown mass. Finally, coming to hypermature cataract, it is a mature cataract that has progressed further, becoming swollen and associated with wrinkled lens capsule. At this stage, the cataract requires surgical removal because it can lead to complications. There are two main types of hypermature cataract. The first one is Morganian cataract, which is a type of hypermature cataract where there is complete cortex is liquefied, which causes dense nucleus to sink inferiorly, and the liquefied cortex appears milky white while the nucleus is seen as a brown mass. And the position of nucleus can change with head position, which is a characteristic feature. The second type is the sclerotic type of hypermature cataract. After this stage of maturity, the cortex becomes disintegrated, and due to leakage of water, the lens becomes shrunken. As a result, the interior capsule becomes thickened and wrinkled. So, hypermature cataract represent an advanced stage of cataract with significant structural changes in the lens. Now, this slide compares cortical cataract with nuclear cataract. Starting with cortical cataract, it typically gives rise to index hypermetropia. This happens because hydration of lens cortex reduces its refractive index, leading to the shift towards farsightedness. On examination, the lens appears grayish white. As the cataract matures, it can become milky white in appearance. Now, coming to nuclear cataract, it causes index myopia. Due to increased refractive index of the nucleus, this results in temporary improvement in the neovision. Because of this, the plus power required for presbyopia gets neutralized, and the patient may be able to read small prints without specs, a phenomena known as second sight. With progression, the lens nucleus appears yellow, then brown, and in advanced stages, it may become black. Lastly, when a patient presents with a gradual painless diminished vision, cataract is mostly the commonest cause. However, it is important to consider other differentials. One important cause is chronic open angle glaucoma. In this condition, vision loss is slow, painless, and may go unnoticed until advanced stages. Then there is macular degeneration where there is progressive painless loss of central vision. Then corneal dystrophies, which can cause gradual painless vision loss due to irregular astigmatism and progressive corneal opacities. Retinopathies associated with systemic disorders such as diabetes mellitus and hypertension can also lead to gradual painless vision loss. Finally, optic atrophy should be considered because here there is painless progressive loss of vision due to damage to the optic nerve and often associated with reduced color vision and visual field defects. Therefore, these conditions should be ruled out before attributing gradual painless loss of vision solely to cataract. Thank you.